Hi, I'm Dr. Steve Jordan from the Andrews Institute in Gulf Breeze, Florida. Today we're going to talk about the systematic examination of the knee. Like all physical examination, history, inspection, palpation, and special tests is what we do. So the history is always really important. Location, duration, onset, and mechanism, how it started, what relieves it, what aggravates it. Another important part of the history that I like to get: what does the patient do? What do they want to do? What do they expect to do in the future? What hobbies do they enjoy? So the first part of this is inspection after you take the history, and I like to watch them walk into the exam room. You look for any asymmetry, any gait abnormality, any difference. The inspection of the gait should include the hips, the knees, and the feet. After that, have them sit on the table. We want to look at range of motion and extension, so go all the way out, very good. All the way down. We're looking at tracking. We're looking at symmetry. Really good extension. Her patellas track good. Then I put my hands over the front of the knee. You feel for crepitance. Go up and down. Next we can do manual muscle tests. Both legs compare. Don't let me push down. Good. Try to bring them back. And you can get a simple screen of the muscle strength side to side. After we do that, I like to have the patient lay supine. For me, that relaxes them better. If they're sitting up, sometimes they tighten their abdominal muscles, but lying supine is a lot better for them to relax. With the patient supine, like to look at their leg and start with the palpation of the anterior knee. So the knee exam is divided into the patellofemoral joint, the meniscal exam, and then ligamentous exam. So of course now we're starting with the anterior knee, the patellofemoral joint. Look for effusion, blot the patella, feel for fluid, feel for patellar tilt, try to bring the lateral side up. 1 to 2 plus is normal, any more is excessive, and any less might be too tight. Then patellar glide. You measure the quadrants. So Ashley has a 2 plus glide. It moves about 50% of the patella across the front of the knee. Another classic test is called meniscal grind test, or also known as Clark's test. Have them tighten their quadriceps and see if it's painful. You can sometimes feel the crepitance when she does that. This test has not been validated. It's probably not that good, and it's probably just painful, but it's still a classic test for anterior knee pain. After that, I like to take the knee up, just to relax her. In 30 degrees, we do the Fairbanks apprehension test. Here we push laterally and see if she has any signs or symptoms of apprehension. Does that feel like it's coming out? So no. If she said yes and you're not sure, you can do the moving valgus apprehension test. So I bring the knee into 30 degrees while pulling the patella laterally, and if she has signs of apprehension that is relieved with medial pressure at the same motion, that's a positive moving apprehension test. Okay? So first we start lateral. If she feels apprehensive, it's going to dislocate. Then we push medial and do the same test. That's the moving apprehension test Chris Ahmad wrote up. After doing the patellofemoral joint, we'll now go to the meniscal test. I like to assess the range of motion again, just to have her relax. Put it at about 90 degrees and start some palpation along the joint lines, anteriorly, mid-body, and posteriorly. At the same time, you can feel in the back of the knee, see if they have any effusion. I like to feel under the patella on the patellar ligament, the tibial tuberosity. Also, at the same time, we feel the collateral ligaments. Insertion of the MCL, attachment on the tibia, do the same thing here. We can put her in the figure of 4 and feel the lateral collateral while we're in this position. Next, we go into the range of motion for the meniscus test. We're going to do McMurray's test. First the medial, externally rotate the leg, go out beyond 90. If it's painful or you feel a click, that's positive. Then the lateral, internally rotate the leg. Extend out beyond 90. Again, you're feeling for pain or a click. Both are a positive McMurray's test. Lipscomb's meniscal grind test, mid-body meniscal test. Valgus varus, as you extend and flex the knee, feeling for a grind or pain. And then finally the bounce home test. Studies have shown if you do these 3 tests plus joint line tenderness, it's the best sensitivity you can have for a meniscus injury. Of course, as we know, the Thessaly test is also very specific, but these are much easier to do while you have the patient on the table. After the meniscal test, we do the ligamentous exam. I like to start with the collateral ligaments. We've already palpated to see if they're tender, but at about 30 degrees, abduction or valgus stress, and see if they gap open. We grade that 1, 2, or 3 plus, 0 if it's tight. Do the same thing with the varus test on the lateral. Also like to put it in the figure of 4 and feel that fiburocollateral like we did earlier. You feel if that's tender, you feel if it's as taut as the other side, so compare the two. Good way to feel the fiburocollateral, figure of 4. So we've done the collaterals, then the cruciate ligaments. Anterior cruciate Lachman's test. She's a little loose with a firm endpoint. I'm going to see if she has a pivot. She's really relaxed well. There's no pivot. From there, we go to the posterior cruciate ligament test, 90 degrees, posterior drawer. If you're not sure, ask them to extend their foot straight on the table. Extend your foot straight out. If you see the tibia move forward, that's called a quadriceps active test. That really helps delineate sometimes if you're not sure if it's a posterior sag or some anterior cruciate ligament looseness. So we've done the quadriceps active test. Then we'll go into the dial test to look at the posterior lateral corner. 30 degrees, put both feet up, and you need an assistant sometimes to do this and measure it. I can do Ashley because she's cooperative. And we look to see if one of the legs externally rotates more than the other. That would signify a posterior lateral corner injury. Having done that, we've done all the systematic tests that you can do for the patellofemoral joint, meniscus, and ligaments. Thank you very much.